Ladies and gentlemen, I'm really happy to present the main results of the research project RightTimePlaceCare. The focus of this project was on transition of people with dementia from home care into institutional care. This is quite sensitive and challenging period for people with dementia and their families. We know that good care for people with dementia starts with early diagnosis, is followed by advanced planning of care, and then providing and receiving care. We know that most of people with dementia live at home and in the community, but nevertheless, almost 90% of people need in some time in their duration of their dementia disease, care home admission. When is the right time? Decision is made by people with dementia and their family members, but I know that they appreciate and even ask for help and advice from professionals. So I hope the evidence we created with this project is a little bit help for all of us to make a shared decision about this sensitive problem. Dementia progresses usually, and the stage where it talks about transitions is usually during moderate or severe dementia, but it depends on help. It depends on availability of services. So it might be there the problem for all stages of dementia. If we talk about appropriate care setting for people in that stage when they decide to go to the care home or not, we have to consider several aspects. Quality of life for people with dementia, but also quality of life and burden of informal caregivers, quality of care and cost of care. All these aspects were analyzed in the project RightTimePlaceCare. This project had target group of people with dementia who were on board of home care and institutional care. What does it mean? People who lived at home and received home care services, but who were deemed to be admitted into a nursing home or care home within 6 months was one group, and another group were people who were recently admitted into a care home 1 to 3 months before our basic baseline assessment. We collected primary data and additional inclusion criteria was age 65 and older, and having informal caregiver who visited a person with dementia at least twice a month. We had structured questionnaires for persons with dementia and their informal caregivers. We assessed factors associated with nursing home admission in people with dementia, quality of life, quality of care of people with dementia, and also their informal caregivers. We made cost analysis. We gathered also information about healthcare structures and patterns of communication. In this stage of our project, we had also people with dementia who participated in group discussions, not in all countries, but still in many countries. We looked at literature, and to summarize all these results, we made a balance of care study. There were 8 countries around different regions, geographical regions of Europe, and covering all different regions. Also different cultures. and different social economic background of these countries: Sweden, Finland, Estonia, England, the Netherlands, Germany, France, and Spain. We had also researchers with diverse background, nurses, social workers, medical doctors, psychiatrists, psychologists, also specialists in health economics. We collected data about 2014 persons with dementia and their informal caregivers. 223 of them lived at home, and 791 were recently admitted into a care home. Follow-up assessment was performed in 3 months. During these 3 months, 126 persons with dementia were transferred into a care home. And now about results. Some of them are really interesting. For example, we didn't find any difference in quality of life for these two settings, home care and long-term care institutions, so quality of life was similar in both settings. We also found that quality of life of people with dementia does not necessarily decrease after admission into a care home. There were approximately half of those whose quality of life stays at the same level, and quarter whose quality of life decreased, but quarter of people with dementia whose quality of life increased, being admitted into a care home. Great variations were found in quality of life and quality of care scores among European countries. In a second, I will show some examples. And depressive symptoms were most consistently associated with lower quality of life. On this slide, on upper figures, you can see quality of life for home care people with dementia, and on lower pictures for institutional care patients. You can see that there is no difference indeed, but the only exception is proxy reports about quality of life from Spain. Spanish informal caregivers and formal caregivers assessed it much worse during institutional care. Some examples about quality of care. There were no some kind of pattern, so we couldn't tell that some countries or some setting was better than another. For example, in Estonia, there were many press ulcers, many physical restraints in Spain, Estonia, and Finland. Many psychotropic medicines were used in France and Spain. So in every country, in every setting, we found better and worse quality of care indicators. Caregiver situation. Informal caregivers at home felt much higher burden compared to those whose close person lived in institutional care. At the same time, health-related quality of life was similar for both groups of informal caregivers. Again, large differences were found between countries. Those informal caregivers whose close one was transferred into a care home during this follow-up period, they showed much lower burden during follow-up and also much lower psychological distress. And here you can see caregiver burden, which was lower for those who took care of people with dementia who were admitted into care homes. But you can also see that differences between countries are quite remarkable. Higher burden was noticed in Estonia and Spain, and lower burden in Finland and the Netherlands, and yeah, probably these were the countries with lowest burden. Cost of care. Not surprisingly, cost was higher for people with dementia who were admitted into a care home. But this must be taken with some caution, because home care costs didn't include housing cost of at home care, which is approximately 15% of the total cost. In all countries, cost in home care increased importantly with disease severity. And if we looked at main components of cost in home care, informal care was the main component, and in care home, care services and accommodation costs were main components. Again, I have to say that big diversities between European countries were seen. Highest cost in home care was noticed in France and Finland, and for institutional care in France and the Netherlands. But lowest cost was in Estonia, it's much lower, and also in Spain. Healthcare structures, not surprisingly, again, we found the same, like similar research as before have found. Significant variations exist in healthcare system, financing, availability of family members, also responsibility, access to care, availability of services. Maybe the only part of our results was where I can say that there were no differences between countries. These were key domains that were really important for people with dementia and their informal caregivers, and also formal caregivers in all countries. Trusting relationship, tailor-made interventions, one specific person or organization to turn to, dyadic approach was appreciated, and adaptation to the needs of people with dementia and informal caregivers. As you see, these results did not tell us which setting was better from the point of view of quality of life, of quality of care. So we tried to combine all these results and made a study called Balance of Care study. This approach gives answers to two questions. Do people receive appropriate services according to expert decisions? And if not, what would be the cost effect of application of most appropriate care? We had real cases. We divided all these cases into groups according to similar needs, and selected 14 of them for group discussions with experts. We wrote vignettes or specific descriptions for these care types, and national expert groups discussed these vignettes, and the goal was to find consensus about the most appropriate care location. We also compared costs of suggested care packages. This is just example how we grouped these case types according dependencies, according living situation, alone, not alone, caregiver burden. And this is just a brief look on one of our vignettes. We described gender, age, functional abilities, physical health, mental health, also informal support. We didn't describe formal support. We wanted experts to create these packages, and attitudes towards future care. The results were quite interesting. Some examples: there were only 2 vignettes where all groups of experts in all countries agreed that this person with dementia better should be cared at home, like Mr. Q. For some case types, attitudes were in favor, in general, in favor for home care and community care, or in favor of care home and nursing home. But we discovered some country-specific features. For example, Mrs. O, in general, community-based care was chosen by experts, but in the Netherlands and France, experts chose institutional-based care. In the contrary, for Mrs. X, mostly groups chose institutional-based care, but some countries, Spain was the one who selected only home-based care. There were also case types where no consensus were found, where there were differences between countries and also within a country. So quite mixed decisions. If we looked where these people really were, and what were suggestions about future care, so we saw that these people who were admitted to care home already, some of these case types experts would prefer to be cared at home or in assisted living. We looked also at cost of care, and we saw that mainly suggested alternative cost of community-based care was lower, also same compared to cost in residential home or nursing home, but there were also some care packages that were much more costly. And conclusions. Health care and dementia care system, along with national care traditions, have major impact on actual place of care, not only needs of people with dementia. Best interests of both people with dementia and informal caregivers should be considered in making decisions about the most appropriate place of care. Considerable number of people with dementia receiving care in long-term care facility could be more appropriately supported in the community if enhanced services, including support for informal caregivers, were available. However, community care is not necessarily always cheaper than care in long-term care facilities. You can find already many published articles about this project, and many more are going on to be published. There will be a special number of Journal of Advanced Nursing, which will gather many articles which provide any evidence about this situation. It will be launched probably at the very beginning of next year. Thank you for your attention.